Hello and welcome to another segment of PA-SOS. My name is Maruf Hossein, and in this segment, we're going to talk about hypertrophic cardiomyopathy. You'll hear me say instead HOCM for the rest of this segment just because it's a lot easier to say HOCM. HOCM is a genetic disorder of the heart where you essentially get hypertrophy of the left ventricular wall. Now, because it's an autosomal dominant genetic disorder, in general, patients will have siblings or parents that also have similar symptoms to them. And sometimes that can be a giveaway that you're dealing with HOCM. Now, while HOCM is something that you are born with because it's a genetic disorder, usually patients don't start having symptoms until their adolescence. So your classic patient will usually be around the age anywhere from 10 all the way to 18. Now, as I said, in HOCM, you essentially have this left ventricle, and more specifically, that septal wall, which is the most common part of the left ventricle that's involved, that gets very large and hypertrophic. Well, you might say, isn't that a good thing that we have a nice, beefy, strong heart? Not necessarily, because we know that when we get that hypertrophic septum and left ventricle, we actually start to diminish the volume of the ventricle itself, meaning that there's a lot less space for blood to actually fill up in that left ventricle. We call that diastolic dysfunction. Remember that during diastole, we normally fill up the left ventricle and the right ventricle with blood. Well, if we're filling up less than we're supposed to, then we have a diastolic dysfunction. This is also a problem because you can imagine that if you have less blood filling up the left ventricle, then you have less blood to push out of the left ventricle. And so there is less blood getting to your other organs, what we call decreased cardiac output. Now, of course, you can imagine that's a problem because less blood getting to other organs like the heart or the brain mean that they can start to have symptoms of decreased perfusion. This hypertrophic septum is also an issue because it can actually cause left ventricular outflow obstruction. You normally have a heart with a left ventricular outflow tract that kind of serves like a hallway between the left ventricle and the aorta. Well, under normal circumstances, blood will easily rush through that left ventricular outflow tract and into the aorta and the remainder of your organs. However, in HOCM, because you have this really thick left ventricular septum, you actually make this left ventricular outflow tract a lot skinnier. It's like trying to rush a ton of kids out of a skinny hallway. Well, in this case, there will be a lot less blood that can actually exit out of the left ventricle, further decreasing your cardiac output. In general, we see that patients will have symptoms, and we'll talk about those shortly, that are classically related to exertion. The reason why is because while you're exerting yourself, your heart will naturally start to beat faster because it thinks, all right, that's how I'm going to get more blood to the remainder of my organs. However, when you beat faster, you actually decrease the amount of time that you are in diastole. Well, we already know that we're having some sort of diastolic dysfunction when it comes to HOCM, but now if you're decreasing diastole even further, that means that there's even less blood that can fill up in your left ventricle. And again, that means that you have even less blood that can leave the heart. We also see something called systolic anterior motion of the mitral valve, or SAM of the mitral valve. The mitral valve actually sits pretty close to this left ventricular outflow tract. And under normal circumstances, these mitral valve leaflets are actually attached to the left ventricle through chordae tendineae and papillary muscles. Well, this left ventricle is humongous. It's very strong, and so every time that it contracts, it will actually pull that mitral valve towards it when it normally should not. Well, that creates two problems. One is that will further increase that outflow obstruction because that mitral valve will start to occlude that hallway even more. But a second problem that you may already see here is that normally the mitral valve should be closed when the left ventricle is contracting in order to prevent blood from going back into the left atrium. But if the mitral valve gets pulled into the left ventricle, that means blood can actually rush into the left atrium as well, and you get, in essence, a mitral regurgitation. Now, that doesn't occur in all forms of HOCM, but it is a possibility, and it's something that you may see on your boards. One of the biggest problems that we see with HOCM are arrhythmias. In general, and it's a good tidbit for you, ventricular tissue that is either hypertrophic or ischemic is much more likely to undergo arrhythmogenesis. Well, in HOCM, you have these very beefy walls that are stretching those cardiac tissue and making them more electrically active. The most common arrhythmias that you will see in hokum is actually ventricular fibrillation, although you may also see atrial fibrillation. Ventricular fibrillation is essentially a form of sudden cardiac death, and that is, again, the biggest thing that we worry about in patients with hokum. Patients with hokum will classically have symptoms related to exertion, and it all is going to be related to a lowered cardiac output. Remember that in hokum, because of all that diastolic dysfunction and the left ventricular outflow obstruction, there is much less blood that is actually filling up that left ventricle, and thus very little blood that is actually able to leave and go to your other organs. Well, if there's less blood going to, for example, your brain, then you're much more likely to pass out and syncopize. If there's less blood going into your coronary arteries to perfuse your heart, you may start to have chest pain or shortness of breath. In very, very severe cases, if you have a drastically lowered amount of blood going to the heart, then a patient may even undergo sudden cardiac death, usually due to ventricular fibrillation. When you're listening to hokum, you will classically hear what we call a harsh crescendo-decrescendo systolic murmur. Now, I do want to mention that this actually is the same murmur that you will hear in aortic stenosis, but we'll talk shortly about how you can actually distinguish this exact sounding murmur from that of aortic stenosis. Now, you may also hear the mitral regurgitant murmur of hollow systolic murmur. Remember that we said that when you have that systolic anterior motion, you can actually cause a little bit of mitral regurgitation. So don't be thrown off if you see this on your board exams. Classically, this harsh crescendo-decrescendo systolic murmur is going to be heard best in the left lower sternal border, or the tricuspid area. And this is actually one of the ways that you can distinguish from aortic stenosis, which is actually heard best in the aortic area, or the right upper sternal border. Another thing that can distinguish hokum from aortic stenosis is what makes hokum sound louder. If you have watched my video on murmurs due to valvular diseases, you'll remember me saying that in general, all valvular murmurs will sound louder whenever there is more blood that is coming back into the heart, or increased preload. Well, we actually see that in hokum, your murmur is going to sound louder with decreased preload, which is the opposite of aortic stenosis. The reasoning is a little bit complex, but take into consideration the fact that murmurs are essentially heard due to turbulent blood flow. When it comes to valves, the more blood that you have rushing past a diseased valve, the louder it's going to sound because there's more turbulence against those diseased valves. While in hokum, most of that noise comes from the fact that you have this very narrow left ventricular outflow tract. However, if you have an increase in preload, meaning there is more blood that is returning to the heart, then you will actually widen that left ventricular outflow tract. Remember that ventricular muscles at the end of the day are still pretty elastic. And so if you increase the amount of blood that is within that left ventricle, it'll actually push that hypertrophic septum out of the way. And therefore, you will have decreased obstruction to outflow. In essence, a decreased preload will make the murmur of hokum louder. The best way to decrease preload is by doing the Valsalva maneuver. In general, the circulatory system is set up so that blood is always moving from high pressure to low pressure. And so when you are performing a Valsalva maneuver, you're essentially increasing the amount of pressure within your thorax. Well, if you're increasing the pressure within your thorax, it'll be much harder for blood to return to the heart, decreasing preload. Again, remember that aortic stenosis will actually sound softer with Valsalva maneuver, just like all of your other valvular murmurs. The best way to diagnose hokum is by performing an echocardiogram. With an echocardiogram, you can actually visualize that hypertrophic septum, but you can also see things like that diastolic dysfunction that we talked about, and even at times that systolic anterior motion. Some things that you might see both in your clinicals as well as on your boards is that they may have EKGs that show left ventricular hypertrophy. And that makes sense because that's essentially what hokum is dealing with. In our EKG segment, we talk much more about how to diagnose left ventricular hypertrophy by reading an EKG, but very quickly, what we essentially do is we take the length of the QRS segments in V1 and either V5 or V6, and we add them up. If they add up to more than 35, we know that we are dealing with left ventricular hypertrophy. Just keep in mind that this left ventricular hypertrophy finding on an EKG is not specific for HOCM. Things like aortic stenosis and a lot of other causes of left ventricular hypertrophy will also give you this exact pattern. But it's something that can increase your suspicion for someone with HOCM. And really the best way to diagnose someone with HOCM on a board exam is by looking at what is your classic presentation of HOCM. Remember that HOCM is a disease of the adolescents. And so you will classically get an adolescent or teenager who is experiencing some sort of chest pain, syncope, or in very severe cases, sudden cardiac death while exerting themselves, such as while playing sports. The management of HOCM is actually going to revolve around trying to maintain a high preload. Remember that when you have HOCM, you essentially have decreased cardiac output. Well, one of the best ways to increase the amount of blood that you're pushing out of the heart is by allowing the heart to stay in diastole a little bit longer so that it can fill up with blood a little bit more. It might sound counterintuitive, but a beta blocker is actually the best way to do that. Beta blockers are very good at decreasing blood pressure, but they also will decrease heart rate. Well, if you're going to decrease the heart rate, you're going to extend your time in diastole and therefore allow for more blood to fill up during that diastolic time. This will essentially increase your cardiac output and will help patients from suffering some of those symptoms like chest pain or sudden death. In patients with very severe HOCM, such as those with very severe wall thickening or with unexplained syncope, things like that, they may benefit from an AICD or an implantable defibrillator. And this is going to be the best way to prevent death because as soon as these patients go into ventricular fibrillation, the AICD will shock them back into a normal rhythm. In patients who fail beta blocker treatment, they can undergo things like myomectomy or alcohol ablation. During a myomectomy, you're actually going to go in and cut that hypertrophied septum so that you can decrease all of that left ventricular outflow tract obstruction and that diastolic dysfunction. Usually we don't have to resort to this, as most cases of HOCM can actually be managed with just beta blocker therapy alone. This ends our segment on HOCM. I hope this was helpful in increasing your understanding of the disease, and as always, good luck. Thank you.